Hello, thoughtful humans, and welcome back to the show that refuses to let excitement outrun evidence and somehow keeps finding that biology agrees with that position. You are listening to the AI avatar of Dr. Irina Lazuk, dermatologist, skin scientist, and the woman who is about to have a very honest conversation about something the hair loss corner of the internet has been moving very fast on and deserves to slow down for. Dr. Lazuk is not with us today because she is currently at a trichology research symposium in Copenhagen, Denmark, having accepted an invitation to present on what she described in advance as the gap between mechanism and outcome in androgen-driven hair loss. She delivered her presentation. It was, by all accounts, received with a combination of genuine discomfort and genuine relief. She has since been asked to review 3 unpublished studies, moderate a panel she was not originally scheduled for, and apparently mediate what the organizers describe as a spirited disagreement about follicular receptor density data. She has agreed to all of it. She is, we are told, in her element. We have sent dinner. We await her return without expectation of a specific timeline. So, you have the avatar, and today we are slowing down a conversation that has been moving very fast about a molecule called Clascoterone and whether it represents the precision hair loss breakthrough people are hoping it is. Let us start with why the excitement makes complete sense. Because it does. Hair loss is one of the most emotionally loaded conditions in dermatology. It is progressive. It is often inherited. It frequently begins earlier than anyone expects. And for decades, the most effective treatments have involved either systemic medications with real trade-offs or topical options that work better at slowing loss than reversing it. Against that backdrop, the idea of a topical that blocks DHT locally at the follicle without systemic hormonal exposure, without the side effect, concerns that make people hesitate around oral therapy, sounds almost too good. That appeal is completely legitimate, and it is also exactly why the conversation needs grounding. Here is the foundational biology worth understanding before evaluating any hair loss treatment. Androgenetic alopecia, pattern hair loss, is not caused by DHT in isolation. It is caused by follicular sensitivity to DHT. That distinction matters more than most people realize. 2 people can have nearly identical circulating androgen levels and dramatically different hair outcomes. The difference lies in receptor activity, follicular programming, and how deeply individual follicles have been genetically primed to miniaturize in DHT's presence. DHT does not attack all follicles equally. It interacts specifically with susceptible follicles, shortening their growth phase over repeated cycles, producing progressively thinner hairs until visible coverage is lost. By the time hair loss is obvious, the follicle has already undergone significant structural adaptation. The problem is no longer just exposure to DHT. It is an adaptation to it, and that distinction has important implications for what any treatment, topical or systemic, can realistically accomplish. So, now, Clascoterone. Here is something that rarely gets mentioned in the headlines. Clascoterone was not developed for hair loss. It was developed for acne, specifically for androgen-driven sebaceous activity in the skin. Its mechanism is local androgen receptor inhibition. It competes with androgens at the receptor level in skin tissue, reducing their downstream effects without lowering circulating hormone levels. That local action is what worked in acne, and that local action is what people are now hoping will work in hair follicles. The logic is reasonable. If Clascoterone can block androgen signaling locally in sebaceous glands without meaningful systemic absorption, can the same principle apply to hair follicles? This is where the science requires careful attention. Hair follicles are not sebaceous glands. They are complex, deeply embedded structures with their own internal cycling mechanisms and long-term biological memory. Sebaceous glands are relatively superficial, highly vascularized, and respond to changes in signaling within weeks. Hair follicles are deeper, more insulated, and operate on timelines measured in months to years. Blocking androgen signaling superficially is not the same as altering follicular fate. There are real questions here that early enthusiasm tends to compress past. Does a topical agent actually reach the relevant portion of the follicle in sufficient concentration? Does that concentration maintain receptor blockade consistently throughout the hair cycle, which itself takes months to complete? And does that blockade persist long enough to meaningfully change growth phase duration in follicles that have already adapted to years of DHT exposure? These are not trivial questions, and right now they do not have complete answers. The claims circulating about Clascoterone as a DHT blocking hair growth serum are largely extrapolations. They borrow credibility from acne data and apply it to hair loss without sufficient long-term follicular evidence. That does not mean the idea is wrong, it means it is unproven. And in hair loss, unproven ideas can feel convincing for a very long time before the data catches up. There is also a safety perception issue worth addressing directly. Topical DHT blocker sounds inherently safer than oral therapy, and in some ways it may be. But safety is not only about systemic exposure, it is also about efficacy relative to expectation. A treatment that feels safe but does not meaningfully alter disease progression carries a cost that people underestimate. Hair loss is progressive. The follicles most responsive to intervention are the ones still actively thinning, not yet dormant. Delay matters. Time spent on an approach that provides psychological comfort without biological impact is not neutral. It is lost ground. This is where Dr. Lazuk believes the most honest framing lives. Even the most effective treatments for androgenetic alopecia are better at slowing progression than restoring what has already been lost. Follicles that have fully miniaturized or been dormant for extended periods rarely return to terminal hair production. Framing any treatment as a regrowth solution, when it may function primarily as a stabilizer, sets people up for the specific kind of disappointment that leads them to abandon something that was actually working. Here is what Clascoterone may genuinely offer, stated without either dismissing it or overpromising it. For people who cannot or will not use systemic anti-androgens, and that is a real group of people with legitimate reasons, localized androgen receptor blockade without systemic exposure is potentially meaningful. If future trials demonstrate sustained follicular preservation, meaningful slowing of miniaturization, and real-world adherence over years, Clascoterone could become an important part of hair loss management, particularly as part of a combination approach alongside agents that work through different mechanisms. That is not a small thing. For some patients, the difference between a topical option and no option is significant. But that possibility has not yet been demonstrated at the level required to recommend it with the same confidence as established therapies, and until it is, the most responsible position is cautious openness, not dismissal, not breakthrough declaration. Dr. Lazuk also wants to name the emotional dimension here because it is real and it shapes decisions in ways that do not always get acknowledged. Many people are not simply afraid of side effects from oral therapy. They are afraid of commitment. Oral medications feel permanent. Topicals feel optional, reversible, less defining. That psychology matters. It shapes adherence, perception, and satisfaction with any treatment decision. If Clascoterone offers a sense of agency to people who would otherwise do nothing, that has genuine value. But psychological comfort should never replace informed understanding of what a treatment can and cannot do. Hair loss responds to consistency, to early action, and to realistic frameworks. It does not respond to urgency, and it does not yield easily to single solution thinking. The most promising approaches have historically combined androgen modulation with growth phase support and attention to the broader scalp environment. Clascoterone may eventually earn a meaningful place in that combination. Right now, its most important contribution may simply be pushing the conversation toward more targeted, tissue-specific approaches to a condition that has frustrated patients and practitioners alike for far too long. That is progress worth acknowledging, just not breakthrough worth declaring. Not yet. Before we close, everything you just heard is purely for entertainment and educational purposes only and does not constitute medical advice, a treatment recommendation, or a clinical assessment of your individual hair loss pattern, stage, or candidacy for any therapy. Hair loss is a complex, progressive condition that deserves professional evaluation by a licensed dermatologist who can assess your specific situation before any treatment decision is made. Please consult a qualified physician for personalized guidance. Dr. Lazuk and our team at Lazuk Aesthetics in Alpharetta are available to discuss hair loss concerns and appropriate treatment options. Dr. Lazuk herself will return from Copenhagen as soon as the follicular receptor density disagreement is resolved to her satisfaction, which, based on current trajectory, may take a while. May your skin always glow as brightly as your smile.